So our next section, get this here. We're going to talk about really probably like a deep dive in critical limb care and how we're trying to do it different. I think it's an important perspective to have an understanding of what happens to somebody if they lose an extremity. And there's a significant change in their lifestyle. And I'm going to introduce Dr. Stephanie Sheridan. Thank you. My brain has stopped, apparently. Stephanie is a nurse practitioner that's worked with VIC for 6 years, and she has her doctorate degree, and she has a passionate for nephrology patients, where she took care of dialysis patients. And she wrote an interesting study on trying to figure out how to reduce amputation rates in the dialysis population by simply checking their feet when they're in dialysis. And I thought that was amazing. We got to meet each other, got talking, and next thing you know, she wanted a job, and here we are. So she's been working with me for 6 years. She's our lead nurse practitioner in the Cleveland location, and in a center that we started there about 3 years ago. She's a graduate from Southern Adventist University, and she maintains her dialysis credentials, and is passionate about taking care of vascular patients. And so I give you Stephanie Sheridan, DNP.
Good morning. And so I wanted a job, and Dr. Lassar wanted the very best nurse practitioner that he could find. Bam. So what you all don't know, he kind of let the cat out the bag. When he was probably planning and thinking about VIC and saving limbs, I was working on my doctorate and in dialysis, and I would see my patients go away for long periods of time. Then they would return with a limb loss, and it was very dismal and sad and depressing. And so as I started thinking of my project, I was like, what can I do to help my patient population? What can I do? So my goal was to prevent amputations, and that's what I wrote my study on. And so he was thinking of saving limbs. I was thinking of preventing amputation. Long story short, great minds think alike. So my goal or my objectives for today are to discuss the aspects of limb amputation, the psychological effects, and also the financial outcomes that happen after these patients have an amputation. So indications for amputation, of course, peripheral artery disease, trauma, tumors, infections, congenital limb deficiencies. And so as we look at this graph, you'll see that 66% of amputations occur in patients that have peripheral artery disease or peripheral vascular disease. 26% affects by trauma, and then there's a combined 8% of tumors and congenital limb abnormalities. If we look at our whole worldwide, there are 230 million people that suffer from peripheral artery disease, and 8.5 of these people live in the United States. Critical limb ischemia is a severe progression of PAD, and we find that about 25% of patients with PAD will progress to critical limb ischemia. We also see that 60% of amputations occur in patients that have diabetes, and more statistical stats that are just very impactful. 60,000 to 75,000 amputations are done annually. And back in 2005, that number of people that were living with amputations was 1.6 million. And then nowadays, we're looking at 2 million, and in 2050, that number is expected to double. So the physical aspects of amputations. So we walked in here today to listen to this conference. So if we think about our mobility, when I'm looking at my patients post BKA procedure and I go to talk to them for discharge, When I'm talking to them, I'm saying, okay, now remember, we just amputated this limb and it's not there. Because what happens when you get up to go to the bathroom at 3 a.m. in the morning, it's not a problem, you just get up and walk in. But after you lose a limb, suddenly you think you can get up at 3 a.m. in the morning, and what does that amputee do? He steps out of the bed, and what happens from that aspect? He falls. And then that creates other issues to kind of go along with the limited mobility. Also, there is pain, and we hear a lot of our patients talk about phantom pain. And phantom pain is very real because our brain and spine is sending messages to our legs. Well, that limb is not there. So the brain gets confused and tries to figure out what's going on. I often will see an amputee in the office and they'll say, I can still feel my big toe. It's right there. I'm wiggling it right now, but it's gone. Infections are a big issue, status post amputation, and about 10 to 30% of patients will develop some type of infection status post amputation. Could be because the incision's not healing appropriately, but those are things that we check out in the office. We want to make sure that the edges are approximated and there is no tunneling of an infection prior to removing any type of staples. Muscle contractions are for sure real, and anytime I see a patient, I don't know why we do it, probably for comfort, we like to stick a pillow up under the knee. And when you stick that pillow up under the knee, if the patients don't remove that pillow, what happens is that muscle gets contracted. Well, as we're trying to work patients up for a prosthesis, it's vital that they stretch that leg out and lay it flat, that they exercise the prosthesis, because when they get the prosthesis, the object is to use that quadricep muscle to raise the prosthesis up and plant it down so you can ambulate again. So, those are all vital. Deep venous thrombus is a risk for any patient having surgery, and a BKA is no different, with about 13 to 20% of patients developing a DVT due to the immobility. Of course, fatigue is an issue because now we have cut off a limb and you need upper body strength now, because now you have to pivot and pick yourself up, move and transfer from A to B. And this is sometimes very difficult for elderly people and women. Other physical effects with amputation, below the knee amputees usually will fare better than our above the knee. Rehab can take as much as 9 months to progress to where they get back to normalcy. And at 2 years, 30% of amputees are still not using their prosthesis. Once again, elderly people and women, along with double amputees, have a very poor prognosis. Psychological effect. It's very similar to like a post-traumatic stress disorder. Basically, they have lost a limb. So they are depressed, isolated. There's the social embarrassment, or what they feel is embarrassment as people are looking at them. There's a deep depression. So patients will require a lot of counseling, a lot of just caring to show that we know what they're going through and be supportive. Post-procedure. Just a lot of stats that I feel like are pretty important just for your reading, but one of the most important stats is not on there. 10% of BKA patients will die before they're discharged from the hospital, and 15 to 20% of AKA patients will pass away before they even get discharged. A third of these patients will never return home. They will go to a nursing home and be there for the rest of their life. And 40% of amputees expire within 2 years. So this is a study done by Ali back in 2005, and it just has on there primary amputation and bypass and angioplasty. But it was done on 417 patients with critical limb ischemia, and the biggest point, or the take-home point I'd like for you all to know, is that out of those statistics, only 16% of those patients were offered an arteriogram prior to amputation. And I just think that's really big. Financial outcomes. Well, it is estimated that 10.6 billion people is the projected cost of what amputations will cost people over time. There's the initial hospitalization, follow-up cost, inpatient rehab, outpatient doctor's visit, occupational and physical therapy, and we haven't even got to the prosthesis yet. And this study was done by Yost in 2014. So if you look at amputations versus vascular disease or revascularization, you'll see that revascularization is so much more affordable than amputation, and also just a better choice for the patient. That just breaks it down a little bit more, talks about mortality, morbidity, revision, but the total cost is still the same. Here's a graph that looks at major amputation, and the major amputation is in the royal blue, and limb salvage is in the dark blue. It is talking about the mortality rate, and what's most significant here, if you look all the way over to 5 years, you see the mortality rate for limb salvage is about 50%, where if we look over towards the major amputation, the mortality rate is a dismal about 21%, 20% after 5 years. Another busy slide, but what is important in this one, in the royal blue is the major amputation, and you can see that that is trending down, whereas endovascular procedures is rising up, which I think is good. So what it's saying is if we're doing more endovascular procedures, we're decreasing the rate of amputation, and what's most significant is the mortality rate is decreasing. So in closing, it is vital that we do all we can to improve patient outcome and reduce the economic burden of amputations. How do we do that? With effective vascular interventions, we can reduce those amputations, decrease readmission rates. And just one little note, it is seen in one of the studies that I read that if we would just try to revascularize or do an arteriogram on CLI or critical limb patients, we can reduce the amputation rate to as low as 90%. Thank you.
She's never going to let me forget that I forgot her name on stage, so just to let you all know that, if you haven't figured that out already. So our next topic is mine, and I'm going to be, let's see if we can get this next one up. So the modern CLI therapy, preserving limbs and function, and as Dr. Melvin said, this is the catastrophe zone. This is where we're going to be talking about, all the horrible things that we end up seeing. But as surgeons, this is, really what we love to do. And patients that present to us with a number of different pathologies. Some is either gangrene of the toe or infarction of the tissue. Sometimes you just have red feet or one foot that's red. We call that rubor. And you can see examples of that here. And sometimes it's a disaster. It's mixed with diabetes, and then we have to do everything we need to do to actually try to save that leg. And so we classify this. You'll see this in the notes when they come back to your office, that they're Rutherford score. And it's fairly simple. Rutherford 1 through 3 is claudication, mild, moderate, severe. Severe being 20 to 50 feet is what I call severe, and usually those people we need to fix. But Rutherford 4 is enough blockage that they're not getting enough blood flow to their feet. Their feet are cold, but they look like they're red hot. It's not red hot, it's red cold. And the arteries are dilated to try to pull as much blood flow into the foot. Rutherford 5 is where you lose tissue. You're going to have surgery. You're going to probably lose a toe or have an operation on the foot. And Rutherford 6 is usually a major defect, and so you're going to lose part of the foot. And so most of these people are in the hospital. Rutherford 6 patients we have to treat in the hospital because it's a multimodal therapy to actually treat these patients. So amputation occurs in about 10% of all CLI patients. It manifests in about 1 million Medicare patients a year. So you keep adding that year on year, and nobody wants surgery. So how do we prevent surgery? Well, this was a patient that was, I say it this way, patients will teach you what's wrong. They'll teach you how to think right. And this is a patient that came to me on a Wednesday clinic. She had a little gangrene of her great toe in that first picture. And I set her up for an angiogram in about 48 hours. And she called me back the next day and said, hey, the blackness is growing into my foot. And I said, go to the emergency room, I'll meet you there. And we took her to the operating room that night. And so she's a 65-year-old female, rapid progression of gangrene of the right foot. She has diabetes, hypertension, CAD. I called her a Rutherford 6 with wet gangrene. So she had wet gangrene as the source. Gangrene, dry gangrene that's turned to infection, which is wet gangrene. And so when we look at this angiogram, we see on the front of the leg, you see the intertibial artery coming down, the dorsal pedal's gone. You don't see the dorsal pedal artery in that area. The posterior tibial artery should be right near the ankle. That's gone. So she essentially has no direct flow from the heart to the forefoot. There's no direct line of connection. It's only the collateral network. And as a surgeon, when we do bypass surgery, there's nothing I can sew the blood vessel to. I can't sew the vein distally to anything because there's nothing there. So the classic answer for this patient is something called a BKA, below the knee amputation. It's a life-saving event for this patient because she has, gas gangrene, wet gangrene. And but I told her there was another option. There's one other thing we can try. And so we used a small needle and put a needle into that occluded artery. And we'll see if this will move forward for us. I'm going to go back. Go forward. Here we go. And so we can see on the right panel, there's a needle in the artery, and we're pushing a small little wire up along that blocked artery to try to get back to an artery above that actually has adequate blood flow. So we can put a little straw in, it's a catheter, and then we can move that wire further up. And what you can see now is that she has 3 blood vessels going to the foot, and that posterior tibial artery leads to the lateral plantar artery, which feeds the foot, and now we actually have flow into the foot. And so to be successful for this patient, you have to understand a concept. It's called the angiosome concept. And plastic surgeons have used this historically for tissue transfers. If they take a tissue, a muscle and skin, and also the arteries and the veins that feed that area, you can move that to a different part of the body, re-anastomose everything, and now you have a tissue transfer. So that same concept is applied into the foot. And so there's a posterior circulation and there's an anterior circulation, and you have to have both. And there was a time where my wife was actually wanting to make multicolored flowers, and she didn't understand why I was going kind of crazy about this. But I said, this is how the body works. When you divide the stems in the red, yellow, purple, blue, you get the dye in different parts of the flower. And so the body works that way, the heart works that way, the foot works that way. And so we call it the angiosome perfusion. So for this patient to be successful, she had to lose the toe. It was gangrenous. And we corrected the circulation to the posterior circulation, anterior circulation. And then we performed surgery to try to close this, and she was able to walk after this. So we maintained her ability to walk. Now, another patient that taught me something very powerful was that a gentleman that presented, about 65, he's got all the risk factors, and he has an ischemic foot. He's having pain, rest pain, and not sleeping at night. And you can see even his heel, when he rests the heel on the bed, it becomes blanched. There's just hardly any blood flow getting into this foot. And so what I recognized was if we're going to be successful for him, we've got to get blood flow to what we call the pedal arch. It's where all of the little blood vessels that come to the toes arise from. And that pedal arch is the connection between the anterior circulation and the posterior circulation. And so the first thing I tried to do is go down the dorsal pedal artery. I couldn't make that connection. And then I connected it via the postertibial artery. And what I learned from this patient was that if I don't get to that pedal arch, if I don't get the flow to the digits, then they're not going to win. So after we did that, we saw 2 weeks. We saw a significant amount of healing. There's some swelling. He's getting a lot of desquamation of the skin. Growing new skin means you have blood flow. So if he's growing new skin, he seems to be fine. And at 4 weeks, he's got a normal foot. And I love that panel because if you look closely at his other leg, he's an amputee. So would he ever walk again being a bilateral amputee? It's doubtful. It's doubtful at his age and his infirmity. So at this point, saving his, his leg, he could actually start to maintain his ability to walk and stay healthy. So this is a 69-year-old white female. She had gangrene of her second toe. She has hypertension, coronary disease, dyslipidemia, former smoker, palpable femoral pulse, and popliteal pulse, but no tibial pulses. And so she put on a pair of new shoes, and she just developed gangrene in this area. We took an angiogram. There's a popliteal artery, 3 vessels that run to the ankle, fairly normal. But she had a critical lesion in the anterotibial artery. And we can use different things now to actually fix this. We can use we'll call rotational atherectomy, which is the middle, which can actually, like a Pac-Man kind of device. We can use a laser. But we actually ended up using the top device, which is called orbital atherectomy. CSI is the ones out there that's the presenting sponsor for that. And they all have the technology out there that you might be able to look at and play with. But we had to fix that artery by using that device to actually get through that blockage. And the other thing that I was always taught as a young doctor was that you don't get gangrene of an extremity or of a foot without having 2 levels of disease. So we went looking for that second level, and we found it in the dorsal pedal artery, which we also treated, and then she improved. And so 2 weeks later, she's got swelling, appropriate swelling. The tissue turgor of the skin is back, desquamation of the skin, and then at 4 weeks, she's basically normal with a perfused foot. So let's talk about Rutherford 4 patient. So this is a test. So I want you to pay attention. You're going to be tested on this. A 47-year-old white male. He presents with pain and numbness to the right toes for 2 months. It's a rest pain style of pain. He had a history of aortic occlusion, status post aortobifemoral bypass. He's 47. He's had a major replacement of his aorta because of PAD. He's a former significant smoker, palpable femoral pulse, popliteal pulse, PT, DP, but his toe pressures were 0. He had no pressure in the toe, but he had a normal ABI. So how could that possibly be? So tell me what you see. I want somebody to tell me what you see. One more time. What you see is capillary refill, and you see it delayed anteriorly. So his anterior circulation is off. So that made me think that maybe there's something wrong with that dorsal pedal artery. So we did an arteriogram. We came down. We did find a lesion in that dorsal pedal. Remember, the blood pressure cuff for the ABI is at the ankle. So if they have a normal artery there, and the blood pressure cuff is normal at the brachial, they'll have an ABI of 1. But he had a critical lesion in that dorsal pedal and a very weak lateral plantar, and so that pedal arch we talked about wasn't getting enough blood flow, and that's why he was having pain. And so we used a device, the rotational device. It's called the Phoenix. I'm going to try it one more. There it is. And we passed it very slowly along that artery to that lesion. It's a Pac-Man device, and so we can kind of touch into that lesion a little bit and back up, and then touch in a little bit more and eat a little bit more of that plaque and actually remove it. And when we do that, then we can use an angioplasty. We almost always do an angioplasty afterwards. And now he's got, adequate perfusion into that foot. And what you see on the exam is that he's got codominant flow now into the foot. We fixed that anterior circulation issue. And more importantly, he told me in the recovery area, he said, "Hey, doc, the pain in my foot's gone." So he surprised me that it was gone that quickly, but it was gone. So we fixed the circuit, the nerves are functioning, he's no longer having pain. This is our 5 patient. 60-year-old white male presenting with gangrene of the left 4th and 5th toes. He's had an angiogram in the past, about 8 weeks prior to this, and had a stent placed, and history of smoking. He's a palpable left femoral pulse, popliteal pulse, postertibial, but non-palpable dorsal pedal artery. And so he presented with gangrene here, and this is a gentleman that's just recently had a procedure and thought he was going to do fine, and then he has development of this gangrene. So we did ultrasound testing of this, including the pedal acceleration times that we were just talked about, that Tina talked about a moment ago. And what we saw is a triphasic pattern of blood flow to the leg, to the lower leg. His pedal acceleration times on that right upper was pretty much normal, class 1 perfusion. And the former doctor that was working with him said, hey, really, there's really nothing to do. There's nothing I can fix. There's really nothing to do. But the test can never supersede a clinical visualization of the problem. You can't say someone has gangrene and that a test says it's normal and that they're normal. They're not normal. You just don't have the right test or don't understand the tests that you really need to get. And so when we did a duplex part of this, we could see that the intertibial had a lesion, and we moved forward with the angiogram, and we found that the intertibial did have a significant lesion, but just below that ankle, he also had a lateral plantar lesion. And so we treated this with a atherectomy, and then we treated the lateral plantar with an angioplasty. And 5 weeks later, he presented back to my office. Dr. Brand, who will be speaking here shortly, performed surgery on him to remove the gangrene. You have to remove that. And now he has a viable foot that he can still walk with. And so it's important that it's a multi-team approach, but that's kind of the process that you have to think about. So this patient is an R6, Rutherford 6, 69-year-old diabetic male, progressive gangrene to the heel, to the right toes, and forefoot. He's a diabetic, dyslipidemic, hypertension, pretty much has all the deal. Former smoker, quit 20 years ago, had a palpable femoral and popliteal pulse, and a DP pulse, but not a palpable PT. So pretty extensive. All the toes are pretty much compromised. The dorsum of the foot is even compromised. And when I saw this, I was like, I'm really afraid he's going to lose his leg. I thought there's really probably no way that we could salvage this. But you have to have that philosophy. No amputation for PAD alone. You can't back away from that. And so I had to learn myself as a surgeon that you had to stick with that philosophy because it can help people. So he did have to remove, we did lose his forefoot. Dr. Solomon performed that operation, and we performed an angiogram afterwards. You have to believe that there's got to be a circulatory reason for the gangrene. Popliteal was fine, and one of the things that we were thinking about is that posterior circulation where the purple line is. That's 2 areas of lesion. And again, 2 lesions means more problems with circulation. And so what we did was repair those because we need the adequate blood flow in that posterior circulation to heal the bottom of the foot. But we also need adequate circulation in the anterior to allow the anterior part of the wound to heal. Now, post-op, he came back 2 months later. He came back a couple of different times, but at the 2-month mark, triphasic waveforms, his PATs were normal, rest pain had resolved, his wound has healed nicely, and he's got a wonderful ability to walk with he'll need a padded shoe. The podiatrist will order all the shoe work that you need, so use them for that, but he's ambulatory at this point. So just a wrap-up case, last case, kind of put it all together. 65-year-old white male presented to the ED with gangrene and cellulitis of the left leg and toe. He had an EF of about 30%, some diabetes, dyslipidemia. He quit smoking in '78. He had a palpable femoral pulse, popliteal pulse, and non-palpable pedal pulses. So this is what he presented with. He had a blister on his toe, diabetic, blister on his toe, and then over a 48-hour period, it just turned black. And he's obviously wanting to save his leg. He's a very big man, so I think walking with a BK would have been extremely problematic for him. And we did the PAT assessment, and it was what we call class 3 perfusion. That's critical, and he just wasn't getting enough circulation into the foot. And so when we did at the findings of the angiogram, we really had 3 levels of the tibials that were occluded. And we can see that the perineal artery had a fairly significant occlusion, near occlusion of that vessel distally, and that was the major vessel really into the foot. So there's a lot of variability of the arteries when we're there actually operating, and it's important to know the different variations. So after we reestablished flow into that medial and lateral plantar artery, what I saw about a week after his post-op was that the posterior aspect of his great toe started to have granulation tissue. He was starting to heal that. But the body does a thing to your ischemic tissue. It will demarcate it. What is alive will stay alive, and what is dead will die, and there will be a line. We call it the line of demarcation. And so his anterior toe really died, and the tendon was exposed. But importantly, the testing showed that he had adequate flow now into the foot. And so this is where I referred him to the podiatrist, said, okay, it's time for surgery. We had a great operation. At 12 weeks, he had, again, normal flow into the foot, and he's healed and was walking fine. And that second toe that he just actually kicked it into the wall, so it's all red and swollen. But other than that, he's doing pretty good. So when we talk about critical limb, it has to do, the main thing that we're trying to do is how do we figure out how to do limb salvage? What players in the community do we need to actually be successful? And if we can save their leg and keep them walking, we can improve and improve their survival. And ultimately, that's really what life's about. No more amputation. All right, thank you. So our next and final speaker for the session is Dr. Will Harris. Will is a surgeon at the Vascular Institute of Chattanooga, my partner, and I'm very proud to have him here as well. He has been a surgeon in the U.S. Air Force and was assigned at Keesler, Nellis, San Antonio, and Fort Sam in Houston. He did his original, he was born in Tucson, and so he did his college at the University of Arizona, graduated medical school from Midwestern University of Arizona, and then did his general surgery at Keesler Medical in the Air Force at that point, and then his fellowship where I met Will at UT Chattanooga. I'd have to brag on him that he was our best fellow that we ever had, and I had an opportunity to steal him back and put him back into this community, and we took that opportunity. He's an assistant professor of surgery at Uniformed Services University of Health Sciences, and also at Lincoln Memorial here in this town. So without further ado, Will Harris.
Hey, thanks for having me. Critical limb ischemia, Chris has already, you're going to hear these words beat into your head over the course of the day, but what Chris has tried to do in this town and what other centers of excellence in the nation have tried to do is establish a huge network. Because obviously when peripheral arterial disease is left unchecked, we go to Stephanie's presentation, we talk about amputation. And we're trying to combat that if at all possible. So early detection, early screening, early intervention is the most important ways to prevent this. A couple other people have touched on this, but we classify peripheral arterial disease based off of Rutherford classification. So when you get a report from us after we've operated on a patient or if we've seen them in clinic, we classify these patients into the level of severity, and that guides our therapy and our aggressiveness. Rutherford 1 and 2, we often don't operate on these patients. It's not lifestyle limiting issues. Those are defined as claudication symptoms. A Rutherford 1 may be a half-mile claudication. Those we tell them to keep walking. And you'll hear later that we really focus on these patients with Rutherford 1 and 2 ischemia on smoking cessation, medical optimization, and risk factor avoidance, weight loss, things like that. Once we start getting into Rutherford 4, 5, and 6, that's when we have were more aggressive, and that's where we get into the realm of critical limb ischemia. Rutherford 4 ischemia is defined as rest pain. Rutherford 5 ischemia is non-healing wounds. And then Rutherford 6 ischemia has developed into frank gangrene. And Chris kind of elaborated on that just a few minutes ago. So obviously Rutherford 4 through 6 is not quite a surgical emergency, but it's bordering on that. So we try and get them treated within, a week of presentation, if not sooner. It's not, it's not unheard of for a patient to show up that morning and be on the table later that afternoon with a form of Rutherford 5 or 6 critical limb ischemia. 300,000 patients in the United States every year develop rest pain, wounds, or gangrene. It is of epidemic proportions. And a lot of these patients present the first time they ever find out that they actually have critical limb ischemia is they have an ulcer that won't heal. I had a patient yesterday who I operated on who presented with a black gangrenous toe, and he had claimed that he stubbed his toe while chasing his dog, and so he was blaming his dog for his wound. He said he didn't have anything wrong with him, but that's also because he doesn't see a doctor with any regularity. It's the Southeastern Tennessee special. He claimed he didn't have diabetes, but his resting blood sugar, his fasting blood sugar was 250, and he was special. So, but he got an operation yesterday. We revascularized him, and then he's going to see a podiatrist in North Georgia later in the week for likely an amputation. So. We optimized them. I texted the podiatrist, fast-tracked that, and got him treated as fast as possible to prevent that gangrene from spreading past his toe. A lot of these patients who they initially start having symptoms, it may be years before they actually report it to their primary care provider or get diagnosed. The estimates are between 2 and 10 years of presentation from the first times they actually develop claudication symptoms or something like that that may be suggestive that they have peripheral arterial disease. And oftentimes these patients wait 3 to 6 months, and sometimes the cat's out of the bag before the point where we can't save a toe or even a limb before they actually start wound care. Upwards of 1 in 5 peripheral arterial disease procedures each year in the United States end up in an amputation. It's a huge number. And 54% of the patients who underwent an amputation did not undergo any attempts at revascularization within the previous year. That number used to be higher. It used to be upwards of 75%. So we're winning the battle. That number has changed over the last even 10 years since I've been in practice, but it is pretty horrible. So our goal is to identify the patients and get them in for screening as quickly as possible. You've probably already seen this slide, but the Partners trial back in the late 2000s looked at people over the age of 70 or between the ages of 50 to 69 with a history of diabetes or smoking, and found upwards of 1/3 of that population have some form of peripheral arterial disease. So I guarantee you have a family member or a close contact who has peripheral arterial disease, 1 in 3, because everybody down here in the Southeast has diabetes and almost everybody seems to smoke. That's why I moved here from Arizona. It was great. But it's a horrible issue. Patients with critical limb ischemia, in year 1, once they present, only 45% will be alive without an amputation. Upwards of 30% after presentation within 1 year with critical limb ischemia will be an amputee of some sort, and upwards of 25% won't be with us anymore. And if in year 5, after presenting with critical limb ischemia, over 60% of those patients will be dead. It's horrible. That's how sick these patients are at a baseline. I tell patients when we actually do have to perform amputations, it's not necessarily the amputation itself that kills them. It's the fact that we're not operating on young, healthy people. I mean, they have a myriad of other problems. And so we're going to talk about, through the course of the day, risk factor modification and identification. A patient who presents with critical limb ischemia, this is an example of our arterial duplex. As you can see, the ankle brachial index is 0.29. A normal ankle brachial index is between 0.9 and 1. So the way I explain it to patients is they have about 30% of the blood flow getting to their foot, and it's probably less than that. So how do we manage this or something like this? I do this before lunch and prevent this. These are our goals. And so, you know, the faster we can get to the point where we identify these patients, obviously the more we can do to prevent the amputation. It's the concept on improving outcomes. So we demand a clinical network. We've developed a clinical network, and we like to call it the center of excellence for optimizing care for these patients. We fast track these patients. If we get a referral, we like to see them within 72 hours, if not 24 to 48 hours. So if we get a text message even from, say, across the mountain in Mont Eagle with a patient with a wound, we expedite their care. We can see them in Jasper, we can see them in our office here in Chattanooga, we can see them soon in Dayton, things like that. We work with the primary care providers, the podiatrists, the wound care providers to optimize their care. And so I can't operate on a patient and expect any sense of wound healing if their hemoglobin A1C is 13. So that's why I send it back to, you know, the PCM or their endocrinologist to optimize them so they would have the best possible outcome. Now, my hand may be forced in a situation like that, and I may have to provide some sort of intervention to temporize them, but that's not going to be a long-term durable solution if their diabetes is out of control. So, I mean, it's so important. I can't help but emphasize how important the teamwork approach is in caring for these patients. You know, working with people like Allison Bailey, who was here earlier, to manage their cardiovascular status. Without a functioning heart, I can't get any blood to the tissues. So, and it also, our goal is to remove barriers to care. So patients in outlying areas who don't see doctors, you know, who live in very rural areas, we discussed earlier that their access to care is horrible. So any barriers that we can do to remove access to care, or to remove the barriers to care, we want to help with that. And again, we want to educate so patients, or so people like you, people on the front lines can identify these patients, be it even in an urgent care setting, primary care setting, or subspecialty setting. And we want to follow these patients for long term to ensure the durability of the repair, to make sure that they don't progress to the point, once we fix them, that they don't fall back. And that means optimizing their health status, optimizing their antiplatelet therapy, their cholesterol medication. So we look at all subsets of specialties. I mean, we get calls from neurologists, we get calls from endocrinologists, and we want to work with them. You know, we have chiropractors that we work with to optimize their musculoskeletal system, to prevent these patients from progressing to an amputation. So, what defines a critical limb center of excellence? We do continuing education. We have people come from all over the country, physicians, people in industry to train with us, to see what we're doing. We engage with industry where we like to work with new products, new emerging technologies. We like to drive innovation. We've talked about doing access from the tibial arteries, using access around the foot. There's nobody else in the country doing it with the volume that we do and with the low complication rate. The complication rate is less than 1% for those kind of accesses. And the patients get up and walk out of the office within an hour. It's pretty amazing after complex revascularization. We've established a referral network. We've got, you know, I can't tell you how many providers' cell phones I have in my phone, and I just text them if I need help or if I want to get them into the hospital. And I ask the same of all of you. If you need something, text one of us. You have all of our, if you want any of our cell phone numbers, come up and ask us for it. And somebody yesterday said that we needed more people to answer our phones at our office. And I said, if you have a problem, text me. I might have some pull as to be able to get a patient into our office at some point. So, and we work on research and publication. We're always striving to make ourselves better and make everybody else better. You know, we want to be a quarterback, but sometimes somebody else is a quarterback. So whoever identifies maybe the problem may be the quarterback, sending them to wound care, sending them to podiatry, sending them to the vascular surgeon for revascularization, sending them to the endocrinologist for appropriate diabetic care. Somebody needs to take a quarterback role. Oftentimes we do, but we're happy to, if somebody else has taken that role for that particular patient, that's great. And oftentimes the primary care manager is the quarterback in managing these patients. They can optimize their medical status and we can be the plumbers. I'm fine with that. So, again, we've talked about the benefits of outpatient care, and that's pretty clear. The cost benefits are we can save upwards of a third of Medicare dollars by performing procedures in our office. The patient doesn't have to walk 150 to 200 yards to get from the hospital parking lot into the hospital. They can walk 20 yards, have their procedure, and be in and out in an hour. They don't have to go through registration. Our quality is, I would argue our quality is excellent. We have more tools than most hospitals actually do in an outpatient surgical center. And, in this era of rationing care in hospital beds, we can avoid putting a patient in a hospital for a complex lung procedure. In the days where we may used to have done a bypass and the patient's holding up an ICU bed for 3 or 4 days, we can do it in 45 minutes and they go home that day. So what can we do better? Looking at diagnosis, improved identification, education of patients, further easy access to care, moving out into rural areas, getting a better referral network from these rural areas. Looking into areas like Georgia, eastern or western North Carolina, rural areas of Tennessee, and we can always improve our access and our procedures. And we can strive to have longer patency in what we do and be even more minimally invasive. So you keep seeing this slide, but it really is important. It takes a village. And we'll open it up for questions. Liz asked me to moderate this.
There you go. Any questions out there? Yes. You raised your hand. I saw it. You were stretching. So when you have a patient that has a profoundly ischemic foot, and you get the circulation back into that part of the foot, a couple things happen. One thing is the body will swell, and that's a natural process. And it must always swells. And then a lot of times they complain of sometimes even increasing pain because the neuro tissue is starting to come back. So you're trying to stabilize that tissue, and so you can operate too soon and then you can lose more from that operation. So one of the things that we always struggle with when you had such a damaged foot is, well, how do you know you have enough circulation? And so when we do the pedal acceleration times, look at the little arteries and look at the waveforms in the arteries, you can actually see whether there's enough circulation. And then you want to give the tissue some time to heal. In that one last case I showed, it was about a week of time to kind of start that healing process, but it was time to move forward. And so that's a kind of a surgical decision. I'd want the podiatrists and the surgeons and the vascular surgeons to work together on when the right time is. But that's about the right time, somewhere between 1 to 4 weeks, depending on healing rates and how the patient is doing clinically. Any other thoughts?
Yeah, I mean, one thing, when we intervene on the very small arteries, oftentimes we'll do surgeries in conjunction with, say, a podiatrist. We'll do an angiogram and a revascularization. They'll go into debride at that time. But when we intervene on the small arteries, especially below the knee, the patency rates and the long-term time that those arteries actually stay open, you're kind of at a ticking time bomb. So you want to get sometimes you will get regeneration of tissues. If you have necrosis of the skin, you'll actually see sloughing of that and regeneration of some skin underneath and things like that. And so a lot of it's about closure too. You have to have some sort of sort of healthy skin to close over a wound once you've done an amputation. So the more you can get of that, that's really important. So it's the provider's best guess.
Any other questions? All right, I think we're doing well on the timing of things. So why don't we move on to our next session right before lunch and get that going?